Thanks so much. Pleasure to be here. Greetings, folks in North Dakota. I suppose the one small silver lining to the, well, copper lining maybe to the pandemic is the ease with which we're now having these kinds of talks via Zoom and other methods. The title of my talk is Before You. I want to make one key point here. Certainly, one could debate, who has the job of deciding someone is competent and or not able to make a decision. And there are certain social structures of authority that might govern that. But especially in the practice of the day-to-day care of geriatric medicine, assessing someone's decisional abilities should be a core part of our engagement and conversations with patients and their families. So the skills here, I think, are applicable to anyone who has a day-to-day contact with patients and their care. Just click on it. Here's my disclosures. Cite PI for some clinical trials at Penn in the Alzheimer's space, not at all relevant to this topic. So I'm going to hope that you're able, by the end of this talk, to define and understand what decision-making ability means, what capacity and what competency mean, have a working knowledge in how to assess each, with a particular emphasis on assessing the decision-making abilities, and then sort of walk away with some sense of how you can incorporate those skills into your daily practice of geriatric medicine. So let me begin with a case, one that I think probably is familiar to all of you, which is an 84-year-old woman. She's in the hospital for pneumonia. Now she's ready to go home. Her daughter comes back from seeing her mother's apartment, and she's discovered 2 mispaid bills and 2 full bottles of medication. And the case manager asks you the question, well, can we send her home? So you say, well, tell the patient, why don't we do this? Just have your daughter come over to your house, set up your pills on a weekly basis, and help you with the finances. So you found this functional problem. You've come up with an easy solution you hope for it, maybe empowered the daughter to be a caregiver, presented to the patient. The patient says, nope, I don't like that compared to what I do. I don't like people coming over to my private place, and I don't want my daughter bothered. So she's refused your intervention. And the question here, is this an intervention you should respect, or is this an intervention refusal that you should do your best to try and reverse, undermine, or otherwise make people aware we've got a problem here? And I think lingering here, of course, is an 85-year-old person who's made mistakes with finances and medications. You're concerned that she may have impairments in cognition that are leading to functional impairments with managing these IADLs. And so already you're beginning to see the kind of connections between cognition and cognitive impairment and impairments in not only doing daily tasks, but solving those daily tasks, solving problems doing those daily tasks. And so, this case is a general example of we believe it's good that adults make or at least participate in their medical decisions if they want to, because we believe that the voluntary choice of a competent adult is a core ethic of medicine, not just of medicine really, but of life. And if someone is unable to make a decision, I'm using strong language here, non-competent, but if they're not able to make a decision, we need someone else to help protect their well-being and help them make decisions or even make them for them. And also, in between the competent and the not competent are persons who need support to make a decision. And so meaning they've got some impairments, but with a little bit of support and help in how to make a decision, they can make the decision. And so this ability almost emerges out of a relationship, if you will, one that we know very well in geriatrics between a patient and their caregiver. If there's a thought I could leave you with here already, which is, what if we, in our practice of geriatric medicine, thought of decision-making capacity as we do activities of daily living? And then what we begin to think is that activities of daily living are a technique that allow us to assess the clinical significance of cognitive impairment, that they add to our innate knowledge of the nature and extent of a patient's disability. And they would improve how we talk about our patients' disabilities, that we would expand not just to being about function, instrumental and basic activities of daily living, but also to an understanding and recognition of impairments and decisional abilities. And so let's take a little closer look at the case. So you gave her a set of options to manage the functional problems, and she gave you back a decision. And then let me break that decision into 2 bits. She expressed a choice, no, I don't want that. And then she engaged in what we would call a little bit of reasoning. I don't like that compared to what I do. I don't like people coming over to my private place, and I don't want my daughter bothered. So that's a little bit of comparative reasoning. You know, your solution versus my the alternative of not, and here's why I think one's better than the other. And you know, so let me break that down and say, well, you know, the first thing she did was she expressed a choice. No, yes, that's it. And this is a study we did of 39 patients with mild to stage dementia to severe stage dementia. And just for a comparison, 13 caregivers who were cognitively unimpaired and busy taking care of these patients. And without getting into gross detail, we're actually measured, you know, can the person express a choice when we gave them a decision to make? And what you can see here is fully all of them could give you a decision. They could tell you a choice. They could express a choice, okay? And so it's a very simple point, but I think it's a very profound point, that if your standard for deciding whether someone has the ability to make a decision is, can they express a choice? I don't want to go to the doctor, or I want to join your research study. If that's all you need to hear, you'd be saying that the vast majority of patients who have dementia are able to make a decision, if that was your standard. Not just the small sample here, but I think in our clinical practices, as long as the patient's verbal, we often find that they're able to express choices. But when you start to look a little closer at other aspects of decisional ability is where you start to see how their cognitive impairments begin to impair their decisional abilities. So this is those same group of patients on an assessment of their ability to comparatively reason. And again, we have ways of measuring this. And you can see here now about half the patients can comparatively reason, and about half are at least mildly impaired, that is to say they're getting a 1 or a 0 on that score. And so the point is that as you start to look at other decisional abilities, you begin to see more variability in performance. In fact, just to spoil the show here, this is the same group of patients now where we assess their ability to understand the decision that they were making. And I'll explain what understanding means in a moment. So just hold your sort of what is understanding. And you can see here now that on this measure, in this case, we used the 10-point scale, that a small fraction understand as well as their caregivers, but a very large sort of fraction, in fact, the majority, have notable impairments in their abilities to understand the information. And so too on a measure of appreciation. So, which I'll show you in another slide. This is another study we did, same point being reiterated. Here we asked a group of patients, again, with mild to severe stage dementia caused by Alzheimer's and a comparison group of caregivers. We presented them a treatment option to manage Alzheimer's disease with a medication. And, you know, we did what any sort of clinician does. We explain the medication's risks and benefits, purpose, and that it was for treating Alzheimer's and would they want to take it. And again, I think what you can see here is the vast majority of the patients were able to say, no, I don't want to take it, or yes, I do. In other words, they were able to express the choice. And again, I think in clinical practice, this iterates what we see. As long as a patient is verbal and attentive to some degree, we can sort of give them information and press a decision, and they'll give us a decision. As in this case, it was whether or not to take this medicine to treat Alzheimer's. And so, you know, I think what I'm trying to get at is a lot of the way we typically go about making decisions with patients who, in general, never mind whether they have dementia or whatever their diagnosis is, whatever reason they're seeing is, we sort of dump a bunch of information on them. And then we say, so what do you want? And they kind of say back, well, you know, I do or I don't. And then maybe we'll say like, well, why or whatever. And that's when we get a lot of comparative and consequential reasoning. And we sort of stop there. And we sort of say, well, you know, okay, I guess she doesn't want it, or I guess she does want it because, etc. And what my point is here is, and if there's another take-home point from this talk, it's to become more skilled in assessing whether someone understands and appreciates the information. And I'll lay out what understanding and appreciation are. I'll give you definitions of them and ways to assess them. And I think that's a real, I think, how to be skilled at assessing decisional capacity. It's to know how to assess understanding and appreciation, what they are and how to assess them. And so what I'm arguing here is we need to more focus on, first, does someone even understand the information? How do they appreciate it before we even get to matters related to choice and reasoning? So let me just give you a little bit of historical background here. I mean, the arc of history has been quite substantially since the 1970s, when, you know, we had these ideas that, you know, to be competent meant you made the decision of a, quote, reasonable person giving rational reasons. Certain broad categories of diagnosis oftentimes just assumed, therefore, the person can't make a decision. Like the statement that someone was senile, which was a term, the shorthand for senile dementia, was often enough to prompt a judge to say, well, then I'll appoint a guardian, without any attention whatsoever to decisional abilities. By the 1990s, there began to be a focus on the functional aspects of decision-making, that it wasn't something that was a categorical status determined basically on the basis simply of having a diagnosis of schizophrenia or dementia or senility, but rather we needed to scrutinize the disorder, whether it was a disorder that impaired decisional capacity, and what its impact was on decisional abilities. And so we arrive now at these core concepts, which have been created over about 20 years of legal and ethical scholarship, of capacity and competency. And so capacity describes the continuum of someone's decision-making abilities. And I'll lay out what the abilities are on this slide in a moment. And so capacity is much like the idea of a capacitance vessel. It fills up and holds things. So, you know, our decisional capacity is a dimensional construct that each of us has with respect to specific decisions. We decide that someone's competent or has adequate capacity based on the judgment of their decision-making abilities. And those abilities are the ability to choose, understand, appreciate, and reason. I've listed them there, and I've evoked them in prior slides as well. And so the key point here is that we make assessments of capacity to make judgments of competency. We assess capacity, and then based on that, we say, you know, I don't think he can make this decision, or I think he can. The default, of course, being that the person has competency. So moving from this status-based approach of give me a diagnosis to assess decisional ability has sort of put on the table, well, give me a decision and I can give you an instrument, if you will, to assess someone's ability to make that decision. And so, you know, like for a while we were part of this cottage industry of instrument development around various decisions, like, you know, the decision to enroll in research, choose a treatment, vote, manage medicines, finances, decide whether to have a genetic test. These are all, you know, instruments that are put out there to help give you some structure to deciding whether someone can make the particular decision. If I can make one appeal to you, is ultimately these instruments, like many of the little cards we use or apps we use, sort of fall away, because once you develop the skills to assess decisional abilities, you kind of almost find you don't need to look at the instrument anymore. So let's start with what the decisional abilities are, and I'll start with the one that I think is, you know, sort of the most important and also the most straightforward in some sense, which is the ability to understand. So understanding describes our ability to comprehend the meaning of information. Having said that, before I dive into this, I've probably reached a natural break point where if someone has a question about what I've said so far, now's the time to either unmute and or, you know, let our moderator know, and you can, you know, ask it, because I'm now going to get into the sort of defining the abilities and how you go about assessing them. So if there's any questions about some of the constructs I laid out before, now's the time to speak up. Did anything come through the chat room, or I haven't heard anyone unmute or ask anything, so I'm going to assume.
Yeah, Dr. Karlawish, Dr. Geriatric here, just wondering, in terms of your study, what was the range of cognitive impairment? Was it mild, moderate, and including severe dementia?
Yeah, so all the studies I've been showing you were individuals who were diagnosed with dementia. So they had disabling cognitive impairments, as opposed to inefficiencies in daily tasks, which would be more like mild cognitive impairment. And they were a mix across the severity of mild stage dementia, moderate to severe. So some assistance with IADLs, mild, moderate, assistance to dependence in IADLs, maybe reminders for BADLs, and then severe, really unable to do IADLs except the most basic of bits of it perhaps, and kind of need a lot of help with BADLs. So that would be the spectrum. I'll show you data later that there's no question measures of overall cognitive severity, like, you know, God love it or bless it, whatever, the mini-mental, that those measures are associated with performance on measures of decisional ability, but they don't substitute for it. You can't just swap out and say, well, what's this cognitive test score? And I'll talk more about that later. So there you are. Any other questions or whatnot?
We don't have anything else in the chat box at this time.
Okay, so understanding. Understanding means that the person can comprehend the meaning of information. It's the most common standard for competency used in the law as well as in the theory of informed consent. And the reason is because it's as value-free as possible. Namely, understanding is simply knowing the facts. Namely, being, and I'll give you questions to assess it. Do you simply know what, say, the purpose of the medicine is, the benefits and risks are? You may not agree with them, you may not think that they're risks or benefits, but can you at least state what they are? And so obviously if someone has troubles encoding information, like such as troubles with short-term memory, well, that's more recalling it, troubles with semantic memory, meaning losing language and the meaning of words, as well as education and literacy, they're going to have trouble on measures of understanding. And I do want to point out that, you know, education and literacy track with how someone does when you ask them about understanding, because given their level of education and literacy, they may either not have been able to grasp the facts and or comprehend them in a way that is different than the way you comprehend them, for example. So how do you assess understanding? And here's a stock phrase I will use in my clinical practice. I'll say, well, look, you know, can you tell me in your own words why, what's the reason for getting the MRI? So can you tell me in your own words, what are and then the factual concept under assessment. So can you tell me in your own words, what's the benefit of getting the PET scan? Can you tell me in your own words, you know, what goes on in an adult day activity program? Can you tell me in your own words what's the downsides of the adult day activity program? So it's this, you know, asking them in their own words to say back facts. And, you know, any parrot can repeat facts verbatim. What you're looking for is the person to paraphrase the meaning of the facts. You know, say it back in their own words, if you will. And so here's that study we did of the ability of patients with dementia to understand the information we presented them about a medication to treat dementia. So again, it was a medicine that was, you know, to treat Alzheimer's disease. And you can see here that a portion of the patients scored as well as their caregivers on understanding the risks, the purpose, risks, and benefit of the medicine. Each question got a 2 point, as many as 2 points, so you get as many as 6. And you can see here that a nearly equal fraction just couldn't understand any of the information. And then there was obviously a mix here. And it's this dimensionality that I want to emphasize. And obviously, therefore, inherently, you can see the judgment of how much do you need to understand in order to have adequate understanding. Do you need to be a 6, or can you be a 3 or 4, or even a 2? And again, these are judgment matters. So next up is the ability to reason. I've already mentioned this ability earlier, namely the case study where the person engaged in some comparative reasoning. I don't like this compared to that. But there's 2 kinds of reasoning: consequential reasoning and comparative reasoning. Consequential reasoning describes our ability to manipulate information in order to identify how it can affect you. And I'll give you a good STEM question I ask for that one. And comparative reasoning asks someone to identify the relative merits or something. And so it's a question that I use to assess comparative reasoning is, regardless of your decision about treatment, having the MRI, going to adult day activity program, regardless of your decision about that, can you tell me how going to the adult day activity program is better than not going? So the reason why I have that stem of regardless of your decision about and then whatever that is, treatment, adult activity program, MRI, taking donepezil, seeing the neurosurgeon, whatever it may be. Can you tell me how X is better than not? And the reason why I put the regardless in there is because a lot of people, they've made up their minds, so to speak. And so what you're trying to do is say, look, I hear what you're saying, you don't want to do it, or you do, but regardless of that, can you tell me how X is better than Y? And so you're hoping that they're going to engage you. Well, I mean, the neurosurgeon might be able to figure out why I'm falling, but I don't have any interest in doing any surgery. Yeah. Okay. And then for consequential reasoning, how might, and then again, whatever the decision is, taking the medicine, not taking it, etc., affect your daily life? I oftentimes, if I really want to get a sense of someone's reasoning, will present them the decision that's opposite to what they've said. So they say, I don't want to go to adult day program. I say, well, how might going to an adult day program affect your daily life? Well, I told you I don't want to go to it. Well, I hear you and I respect that, but just in your own words, how might going to that affect your daily life? How is it better than not going? And so I'm trying to see if they can see the other side, if you will, not because I want to fight with them or I disagree, but I want to get a sense, do they have any ability to reason about this decision? And again, reasoning, here's the measure, same group of patients. Again, this is a 10-point range here on these measures of reasoning. And you can see some patients reason just as well as their caregivers, in fact, a fairly decent number. But also you can see that a fairly decent number couldn't really engage in any substantive reasoning. And, again, it iterates the point that if you don't assess these things, you won't know about it. Next is the ability to appreciate. This is in everything I've been saying and everything that I will say about assessing decisional abilities, assessing decisional capacity. Everything that I've been saying is pretty agnostic to the disease in question. I know that the talk was framed as a talk about persons with dementia, but I hope that you recognize, gee, I don't think anything that he said here is terribly unique or specific to the diagnosis of dementia. That is to say, this would be of value in the care of, say, someone with a developmental disorder who's now an adult. Or it would be relevant in the care of someone who's had a stroke or any other disorder that might impair their cognitive function. And you're exactly right. Having said that, though, of all the decisional abilities that's uniquely and distinctly impaired, I think, is the ability to appreciate, uniquely and distinctly impaired by dementia. And I'll talk more about that. So this ability describes your ability to recognize how facts apply to you. And so there are different, if you will, subtypes of appreciation. Do you appreciate your disorder, your illness? Do you appreciate your prognosis and do you appreciate the benefits and the risks of options? What appreciation requires is that someone assign values to information. So for example, I'll give you examples actually. I think it's better to kind of walk you through what I mean by that. But unlike understanding, which is do you know the facts, appreciation is saying, given the values you hold, how do you perceive the risks and benefits and reasons for an intervention as they apply to you as a person? So this is a value that's, a decisional ability that's getting at the heart of why we care about decisional ability, because it's letting someone express their self-determination, their identity. They hold certain values about things that matter to them, which is why something may be perceived as a great risk when we don't think it's a risk, or vice versa, not at all risky when we think it's risky. And it's not to judge that their values are wrong or right, but it's to get a sense of how coherent and consistent are their values. And so where we get bothered about a person's performances on measures of appreciation, or if they have a distortion of reality, if their perception of reality seems so distorted that we feel that they're not making a decision that respects their autonomy. And so how you might assess someone's ability to appreciate the problem is, I like this question. Well, can you tell me in your words, what's your medical problem? I use this question or variations on this question a lot in my practice at the Memory Center. So when I reach that point at the end of a visit where it's kind of like time to kind of make a plan, you know, and granted, they've come to the Memory Center, you know, so there's something going on about memory maybe, you know, and I've been asking them questions about their memory and tested their cognition. So, I mean, they're a little primed, both because of where they are and what's happened. So, you know, when it comes time now, let's make a plan. What I'll do is I'll say, well, you know, let's wrap up here, but just tell me in your own words why it is you see me here at the Memory Center. Which again, I'm saying Memory Center, I'm kind of, you know, there's a reason for being here that probably has to do with memory as opposed to dyspnea, pain, etc. So, you know, why are you seeing me here at the Memory Center? Sometimes they'll sort of look at me like, oh, well, what's the problem? What am I treating you for? And what I'm trying to get them to say is, well, my memory, it's not that good, or Alzheimer's, or dementia, or I don't know. I mean, my wife brings me here. I really don't think there's a problem. You know, I'm happy to talk with you, etc. I find that extremely helpful to find out to what degree do they sort of recognize why they're seeing me, and to the degree they think there's a problem. And I think many of us who practice, you know, in the space of geriatric medicine, where we see, you know, in a typical geriatric practice, about 25% of a practice has dementia, another 25% has MCI, and the other half doesn't. So, you know, so your pretest probability of cognitive impairment is nearly 50%. And I think, you know, one of the things we all recognize is that patients have quite variable appreciation of their deficits, both the diagnosis, but also its functional implications. And I'll show you some data on that in a minute. Before I do, the other aspect of appreciation that I mentioned was the ability to appreciate risk and benefit. So again, that regardless of your decision, because again, you know, oftentimes these conversations about decisional ability unfold in the setting of someone saying no to something that you think they ought to do. Doesn't mean you got to force them, but you at least want to make sure, you know, they're making the decision that they want to make. So regardless of your decision about having the MRI, can you tell me what you see as the benefit of the MRI? Regardless of your decision about, you know, taking the aducanumab, can you tell me what you see as the risks of aducanumab, a drug that has been tested for persons with Alzheimer's that got as far as FDA review recently? You know, do you think it's possible that this treatment might benefit you? Do you think it's possible this treatment might harm you? Why or why not? And again, these kind of STEM questions, you know, if those studies I showed you where I showed you data where you know, they scored an X or whatever, it's what we do is we ask them these questions and then we have scoring criteria to say, oh, I think they pretty much adequately appreciate the benefits, I'll give it a 2, versus marginally, I'll give it a 1, versus not, I'll give it a 0. So that's how we use these questions and then score people's answers. But you can just as well use these questions in your clinical practice, whether they were having to put a score on. So I've been sort of dancing around this a bit about, you know, what's unique about persons with dementia. I think it is the issue of their ability to appreciate. And so again, that group of patients who had dementia asked to consider a treatment for Alzheimer's disease dementia. And, you know, I think this data table shows it. So first we'll start with their caregivers. The majority of the caregivers could appreciate the risk and benefit of the medicine, as you can see here. But what's interesting is that a fairly large proportion of the patients could appreciate the risk. I'll just tell you, the risk was GI bleeding. We modeled the medication after a non-steroidal. And so, you know, a fairly large number of the folks could appreciate that GI bleeding was a risk of the medication and what that meant. But you can see here a real difference in their performance on the ability to appreciate benefit. In other words, nearly the opposite span here of people not able to see how a medicine could benefit them. And it's probably, I think, not probably, it is, because empirically we showed that the troubles with appreciating benefit were wrapped up in this, which is their insight into their diagnosis. Insight being another way to say appreciation of diagnosis. In other words, when someone says, I don't think he has any insight into his diagnosis, it's a neuropsychological way of saying appreciation of diagnosis. So the ethical term is appreciation. the neuropsychological term is insight, or the neuroscience term is insight. Another term is anosognosia. He has no awareness of his problem. And so this is a group of patients, different study, just to give you better numbers, but we asked these patients who had a diagnosis of Alzheimer's disease, dementia, do you have any problems with your memory or thinking? Would you say yes or no? And you can see here, it's very interesting, about 40% of the patients said, yeah, I've got some problems with memory and thinking. Another chunk said that they didn't. And it is certainly the case that many patients are symptomatic. They will say, yeah, no, my memory is not that good. Then we asked them if they said yes, they did. We asked them, will those problems get worse? And if they didn't say they had any problems with memory and thinking, we didn't ask them this question, of course, because it would make no sense. But what you could see here is that a smaller but still a notable fraction of individuals did feel that they had problems with their memory and thinking, and that they would get worse. So they had appreciation of their prognosis. And then we asked them, no matter what they said about memory, yes or no, well, do you have Alzheimer's or dementia? And what you can see here is that a smaller fraction of individuals said, no, I said, yes, I do. So, I think the point here is that compared to the caregivers, all of them said, well, yeah, he has problems with his memory. Of course, they're going to get worse. And yeah, he's got Alzheimer's or dementia. So I think it's a nice juxtaposition to show the variability in patients' insight into their diagnosis, prognosis, and symptomatology or signs, if you will. And this, we find, correlates well with how they do on measures of appreciation and benefit of a medication for treatment. So very important ability, and one that I think in the care of persons living with dementia, I think a smart geriatrician, a practitioner, geriatrics practitioner, will become skilled in how to assess appreciation in a non-threatening way. But again, I said this, but in my clinical practice, I make great efforts to kind of get a sense of, are they aware of their problems? What do they think is causing them, etc. So, so I talked about judgment. You have to assess the decisional abilities and make a judgment. In our studies, what we'll do is we'll record the interviews with these patients and then have experts in capacity assessment, typically consult liaison psychiatrists, listen to the interviews and judge, do you think the person's able to make the decision or not? And this is just looking at the agreement across those experts. First, the proportion, each expert's judgment of whether the folks whose interview they listened to are competent, and then the agreements here. And these agreements, you could debate these captives till the days come. They're not 0.8, but they're not 0. They show that there's some decent agreement amongst the experts. And of course, what's going on here is that some of these experts are weighing different things. Like this expert arguably is a bit harsh, only about a third, whereas this expert's arguably a bit lenient, about 2/3 are competent. And they're weighing arguably different things, if you will. So Dr. Geriatric asked me this earlier, and I gestured to the fact that there are relationships, obviously, between cognition and decisional ability. I mean, that only makes sense. I mean, if someone's completely cognitively unimpaired, with a solid skills and literacy, they're probably going to be capable of making most decisions, assuming they learn the information. And in contrast to someone who's profoundly cognitively impaired, they probably are not going to be able to make decisions, right? The issue is the in-between, and it's sort of like heart attack. You come and you say, I've got an elephant on my chest, last 30 minutes, and I'm sweating and short of breath. It's either dissecting an aortic aneurysm or it's an anterior wall MI. It's the subtle cases of cardiac chest pain that require our attention and our skill set. And so what I'm simply showing here is that, in many mentals that are in the range typically for sort of, moderate to severe stage dementia, you can see a small portion of folks are competent. And in many mentals that are in the range considered mild stage dementia, the majority are competent. But you can't assume on either end. There's a proportion who are or aren't. And then really the issue most notable is in that middle range there is, the variability you see. So if you can certainly look at the mini-mental and raise or lower your pretest probability that the person will have impairments, but you certainly don't want your mini-mental just to sort of say, oh, well, he clearly can make the decision or he clearly can't make the decision. Moreover, even if I could give you a cognitive test battery that could perfectly decide There's a dignitary harm of like saying, well, I'm not going to talk to the patient. I'm just going to look at those cognitive test scores. I mean, dignity would demand talking to people and having a conversation. I mean, these are adults, for God's sake. So, back to that case I gave you, we developed this instrument, the assessment of capacity to make everyday decisions, to try and help guide probably one of the most vexing decisions, in clinical practice. Decisions about treatments, medications, the sort of biomedical stuff, yeah, you got to get informed consent. It's these day-to-day decisions where people say no for interventions that we think will help them, where we're like, she doesn't want it. Oh, okay, I guess she doesn't want it. Well, in some sense, we should think of them just like decisions around treatments, medications, diagnostic workups. We're going to respect their autonomy and let them choose after we've given them adequate information, but we really ought to assess their capacity to make that decision. And so the ACE we designed, to assess, do they understand and appreciate the problem? Do they understand and appreciate the options to manage the problem? Where the problem was things like confusing medications, having trouble paying bills because you've seen a bunch of mispaid or double paid bills, and giving someone options for managing financial tasks, and they say, nope, I'm fine, leave me alone. I don't, well, walk them through what are some other options. Do they appreciate the benefits of those options, et cetera, to see whether they really have the ability to make the decision how to manage their functional problem. Or as often is the case, you uncover their misunderstandings or misappreciations and arrive at a sort of a more amicable agreement about what we're going to do to help manage those functional problems. And so the ACE was designed to do that. We find we get a lot of requests for this instruments from people who work in adult protective services, because they're at the ground zero of cases of neglect and abuse, et cetera, where someone is offered interventions to manage the self-neglect or the abuse, and they say, no, I don't want it. I'm fine. And in those kinds of cases, the concern is, well, is this person able to refuse this intervention for this imminent risk? And so APS workers, that's what they struggle with. Now, what we found from studies is they would do like the short portable mental status question. If the person scored fine, they'd say, well, he's normal, so he must be able to make the decision. And I think, as I've showed you from the data around cognition, it's just simply inappropriate to rely on some cognitive test to say someone can or can't make a decision. It certainly informs, as I say, the likelihood that they may have problems, but it just can't substitute for that. And so we've been engaged in a lot of work, our colleagues at Cornell University and myself, in trying to disseminate into the world of adult protective services skill set training and how to assess decisional abilities by giving lectures like this, for example. So I showed you that, data already, actually, so this was 39 patients with known functional problems, troubles managing medicines, troubles managing finances, troubles with cooking. And, all of them could give you a choice about options to manage things. But what we found, of course, as I showed you, was, they could also, many of them could reason, but the problem that, I've showed you these data before, was many of them had a lot of trouble understanding what the options were. And many of them had a lot of trouble appreciating the risks and benefits of those options, okay? And this is really where we found most folks kind of had trouble. They just couldn't see how it would benefit them because they just didn't see that they had a problem, if you know what I mean. And this is an issue even in persons with mild cognitive impairment. And it's why I think, as a clinician practicing in geriatric medicine, and myself, I pretty much focus only on persons with memory disorders. But I hope that you've come away with how valuable knowing what the decisional abilities are, and then B, having hardwired into your practice ways to assess them can really help you go, gee, I don't think he really can make this decision. Now, that doesn't mean you're going to shove the pill down his throat or force someone to come to his house who he's not going to let in, but you should at least know, I got a guy at risk here. And, oftentimes for us, that's why we rally the family and say, I'm really concerned. Your dad has come into the ER, 4 or 5 times in the last month, with hypoglycemia. He's just having a hard time managing his medicines. And when we offered, the visiting nurse to come by once a week to the pillbox, he says, no, leave me alone. Well, he doesn't get that he's making these mistakes, and, families come together and the care systems come together to help people sort those things out. So there are instruments that exist that can structure how we decide someone can make a decision. And they focus on decisional abilities, not whether something's reasonable, and certainly not on diagnosis or just measures of cognition. Those instruments like the ACE specify the abilities we ought to care about. They help us show, like, he just doesn't understand these facts, as much as I try to explain them, or whatever it may be. Or, they allow us to see the clinical significance of cognitive impairment. In other words, what does it mean to have a mini-mental of 18? Love it or hate it, I would argue that's a score in the mini-mental below which things get really tendentious for people to solve problems because they're really having trouble with attention and concentration. The more we know this language of decisional abilities, the more we as practitioners can have coherent conversations about why we're doing or not doing things for a patient. And there's nothing more painful than listening to us talk with each other about our patient's cognition and decisional abilities. I mean, it's like incoherence. Like, well, he just doesn't get it. He's kind of out of it and a little goofy. That is like not very helpful language. Whereas being able to say, well, he's got real problems with appreciation of disorder. I mean, he just thinks there's nothing wrong, etc. Or he's so inattentive that you ask him and he's just wandering off on the topic. I can't even get him to focus. He'll tell you he doesn't want to do it, but the conversations, I can't get him to focus.
One screen looks like I'm paying complete attention to you, and the other one looks like I could care less about anything.
Totally blowing me off, yeah.
So I was gonna do that to express the point that decision depends on our perspective, like how we decide to see someone or a problem. So I was going to ask you, and I wrote down the questions, that's what I'm looking at. Have you looked into, or what kind of tools or methods or resources assist in changing perhaps or enhancing, I don't know which word to use, but changing or enhancing their, older adults' perspective to enhance their ability to appreciate? So, yeah.
Two things. One is a direct answer to your question, and the other is trust. So one reason why people don't want to do something is they don't trust you at all, or just suspicious. So sometimes cases of decisional capacity are not about capacity, they're about trust or lack of trust. And so just keep that in mind. Someone just doesn't buy this whole place and is just not going for it. So I just want to put that out there. So how to enhance appreciation? I kind of hinted at it already a bit. Like when I test someone's cognition, I'll ask them, so how do you think you did? And because it's almost like putting them on the treadmill when they've got, say, COPD or coronary vascular disease. I've elicited symptoms. And I want to see, do you recognize that? And I'll often say, well, it looks, I'll say, well, you had some trouble there on the memory measure. That seems to be this memory problem that your husband has noted, or your daughter brought you in about, or that I've noticed, or that has me concerned. Are you concerned about your memory problem? And oftentimes I'll say, yeah, well, yeah, I am, or they'll say, no, I'm not, or I didn't think it was important to remember that, so that's why I didn't remember it, So, and then also when I make them do a memory task, I'll say, now I want you to remember that because I'm going to ask it to you later. Okay. And that's why I do that with my memory task. And I'll say, well, no, I asked you to remember that address. I did. And sometimes they've forgotten that. They're so profoundly amnestic, But again, the summary point is to help augment appreciation is without being brutal, while being kind, but being what we are as clinicians, helping them to bring out the signs or symptoms and recognize them. The other thing I do is, and COVID has somewhat made this more happening, because I'm interviewing people online. I used to interview patients' family members separately and then bring them together. But now oftentimes they're in the same room for the entire visit, which is a little weird. I say, do you want some separate time? And sometimes I send them away, certainly when I examine the patient. But I will say, like, well, your daughter noticed that, that there was some troubles with the checkbook. And I'll try and bring that out. I'm not trying to create a fight here in front of me, but, is there some acknowledgement by bringing up the functional problems and or bringing out the cognitive problems? that causes someone to have some degree of, oh yeah, well, you're right. I do get what you're saying. Yeah. So in summary, that's one of the main ways I try to sort of enhance appreciation in individuals. Yeah. Any thoughts, comments, or reactions? Other questions, comments? I will say that because we're, doctor means teacher, our job is to teach our patients things. In some sense, our patient's ability to make decisions is only as good as our ability to be a teacher. And so you could make a lot of patients, I'm sort of building on Jeremy's question, I can make a lot of patients look impaired if I do a lousy job telling them things, because they're just sort of, overwhelmed with this just, lather of stuff. So I'll give you another pearl, what I use when I talk to patients. We love to talk. I mean, I've talked now for almost 60 straight minutes. But when I sort of dump information on patients, I have a very deliberate habit now of kind of chunking it out. And I'll say, well, now let me stop, because I said a lot of things, and I want to just take a pause here and see if you have any questions about what I've said so far. And then I'll wait like 3 or 4 seconds. And a lot of folks all of a sudden will sort of pop something out, and oftentimes it's a dramatic misunderstanding or misappreciation of what I've said. And it's because, I'm giving them piles of new information, nuanced issues and whatnot. So that's another technique I do to try and enhance decisional ability. And then a third thing I'll do to enhance decisional ability is back to this idea of supported decision-making. I more and more see the caregiver not just as the doer, like, pay the bills, cook the meal, that stuff, but as the help with decision-making, and to try and really train people. And, I used to be kind of skeptical about the value of the MCI diagnosis. Like, what the hell's the point of it? And I think there's one value to it that I've come to more recognize is, because of this personally, my father has MCI from Alzheimer's, is I'm in his life now helping him make decisions. And I can't tell you, actually back to your question, Jeremy, how helpful it is that he accepts my help now, which gives me some hope as he gets more impaired, that he's comfortable with me. Because we all know clinically, the most painful clinical scenarios are when they come in with the emergency. And you're like, okay, well, let's do this, this, and this. And the patient is, by this point, so impaired, suspicious, et cetera, that you can't get anything done. And the family is at wit's end, et cetera. And so in summary, I think early diagnosis has a value to create kind of a supported decision-making structure around the person. Not to take over my father's decision-making, but I look at his checkbook. I have a nurse come by every 2 weeks to check on his meds. And, and we're watching, and he trusts it. And so, there will be problems. I can see them emerging. He's having more semantic memory problems, so, we'll see. But I'm hopeful that he'll be more accepting rather than me barging in when there's problems where it's like, where did this come from? So long answer to your question, but really you got to sort of, I think, the heart of some of the sort of challenges that are unique to dementia, more so than some of the other disorders.
So Dr. Karlawish, I was going to ask, how much variability within a individual for decision-making capacity? Are there good days? Are there bad days?
Well, so yeah. So the answer is, of course, there are good days and bad days. Just I don't know about you, but catch me in the morning and forget it. Midday, I'm great, whatever. So there's just the diurnal variation of our attentional abilities, and to the extent that attention can vary, your decisional ability is going to vary. But I mean, some of the diseases we deal with, decisional ability varies, and the sine qua non disease is Lewy body disease. I mean, the families will tell you he's got good days and bad days when they're really alert and on, and then just have tremendous problems with attention and alertness. And it's really quite variable. It's that in Lewy body disease. And then we've done empirically within subject studies where, we showed that a person, depending on the nature of the decision, obviously decisional ability varies. So we showed empirically that patients with Alzheimer's disease, dementia, many of them retain the ability to appoint a proxy. In other words, they could work through the decision to say, go ahead and talk to my son in a way that you felt that was an appropriate delegation of authority. But when we would present them a research protocol that they could enroll in, they couldn't do it. So I think a lot of it gets to the novelty of the information, the complexity and whatnot. So that gets back to, kind of every decision is up for assessment in some sense. You just can't assume. Granted, floor and ceiling effects operate. I mean, some patients are so profoundly impaired that you're kind of not able to make decisions other than matters of preference and choice around food or things like that. Any other questions? We're sort of the top of the hour, so I don't want to cut it off, but we probably need to wrap it up. It's been great fun. It's the first time I've ever been to North Dakota. If you all ever make it to Philadelphia, give a holler. It's a little more hilly.
Sounds good. And I appreciate your presentation. Really outstanding.
Thanks,
And,
Don.
I think it's a lot of the good news. It's got really some practical applications that we all need to use in our clinical practices.
Thanks. Yeah, that's my key point, that if there's any one takeaway, it's sure, for tough cases you need psychiatry, but this should be part and parcel of the practice of geriatric medicine. It's no different than being able to measure cognition or listen to a heart or check a gait. So yeah.
Yeah.